Hello. Welcome to another live episode. Next live episode. All right, guys. Today we are talking about myths of perimenopause, common myths that some people might have. Love these. So, thank you so much for joining me today. I am Dr. Nicole Smith. I am the founder of Antigravity Wellness. I specialize in the care of the perimenopausal and menopausal woman. We're going to talk more about what the heck that is. I started my journey a long time ago, but as far as perimenopause is concerned, I was about 37 when I started to notice that something was off. I hadn't changed anything. I was still being really consistent with my routine, but I was having a lot more fatigue, which I've battled for a really long time and had finally actually gotten feeling better. The fatigue was back, and I had worse PMS symptoms that were starting way early that I had not had before. And I was like, what is going on here? So I saw my primary care, I saw my OB, we ran regular labs, and they're like, everything looks fine. I'm like, yeah, but I don't feel fine. And it's been over 3 months, and this is a consistent pattern. And I know enough that this isn't right. So I found the help of a naturopathic doctor, and she dived in some more with my labs. We found out my thyroid was a little bit sluggish. My T3 was low. No wonder why I was tired. And then my progesterone was low. So no wonder why I had these weird PMS symptoms that were coming out of nowhere. I was acting estrogen dominant, even though my estrogen levels were fine. That's an early sign of perimenopause. Had no idea, never even knew that was a thing. And I work in the medical profession. I was trained as a family nurse practitioner. We didn't talk about this. So I had to go somewhere else to get all of this other training that now I've integrated into my own private practice here at Antigravity Wellness, and has made all the difference for my clients. I do so much with just your basic, I do, meal plans and fitness plans, and we really clean up their lifestyle and their diet. But it was that extra layer that we needed. And especially going through this transition, we need a little bit of extra help. We might need some herbal supplements. We might need some Vitex. We might need some DIM. We might actually need to be on hormone replacement. So knowing that now, I'm able to help people a lot better. And that is what I love sharing with you guys, is how this whole process works. Educate yourselves so that you are more empowered when you do go to your primary care to kind of put your foot down and be like, look, no, I know what I'm going through is probably perimenopause. I need certain labs drawn, in order to see what's going on in there. Or, maybe I need to go find another practitioner who is more versed in this and more open to treating it. Because unfortunately, there's still a lot of resistance out there with the primary care providers. And it's not like I give them a lot of credit. I did not go into family practice for a reason. It would have burned me out very, very quickly. So I have a lot of empathy for family nurse practitioners and family doctors. They're really stretched thin. So I understand. And this is kind of complicated. Now that I'm doing it, I've been doing it for a few years now, it doesn't seem so complicated. It's actually kind of fun for me. I really love being able to do this work, to dig in, figure out what's going on with the woman, and then go, oh, okay, so I see this, this, and this, and then this lines up with your symptoms here. So let's just tweak a few things here and there. And then boom, within a few weeks, they're a totally different woman. It's amazing. It's so fun. So we're going to talk about myth number 1, that perimenopause only happens after 50. Yeah. So we weren't taught about this. We think you just go through life and then you hit 50 and then you got to worry about menopause, right? No, it can happen as early as age 35. So I want to show you guys something. Let's see if my camera will move with me. I twisted this guy up because it was moving too much. Pardon me. Pardon my reach, guys. Here we go. There we go. Okay. So this is straw plus 10. So this is for diagnosing, quantifying perimenopause and menopause. This was not ever anything that I ever saw in nursing school or the FNP program. But this is part of my training and studying for the menopause board exam. So, oh, excuse me. Okay. So we have the menarche, which is your first menstrual cycle, the first time you ever had a bleed. For a lot of women that I talk to, that's like age 12 for many. And then we've got like so 0 is menopause. And then so it's minus down there and then plus up here. It's kind of weird, but this is how they decided to do it because, things got to be confusing, right? So you've got your reproductive years down here. And then, but even towards the end of the reproductive years, we can start to see some symptoms, some subtle changes in the flow and in the cycle. And this can happen as early as age 35, although I've talked to some women and it's happened even in their early 30s. So if they have any type of autoimmune condition or GI issues or thyroid or adrenal, we can start to get into kind of like an early perimenopause situation. So this can happen early. And then we go into the menopause transition. This is typically what we think of as the 40s. So we've got the early and then the late, tend to be like the last 1 to 3 years, depending on when you go through menopause itself. So that I've seen average of 50.8 years old or 52 years old. But it also depends on your family history. So ask your mom, unless she had a hysterectomy, like a lot of our moms did, right? Because that was like a big thing, like very trendy to just get your uterus ripped out of your body. So we have this early transition, variable length in the cycles. So you have changes within about 7 days. And if you're not tracking your cycle, and by the way, we're going to do maybe tomorrow's Wednesday, Thursday, I will show you guys another chart where we're going to talk about the actual cycle, because if you're not tracking your cycle, it's going to be really hard for us to know what's going on. So it's very, very important you're tracking your cycle. And we're going to talk more about that. Again, another thing that we just didn't learn enough about our own bodies. Like body literacy is a thing and we should have it. Okay. So then we get into the late transition. We start to have skip cycles. So this is where you're going to go like a month or 2, maybe even 3 months without a cycle, which can be kind of terrifying because you're like, am I pregnant? It's not good. I'm too old to have babies. Yeah, some people would say not, but anyways, so you can start to have skip cycles, or we can have anovulatory cycles, which means you can have a bleed, but you didn't actually ovulate. So the body's starting to slow down on that. The FSH, this comes from the brain. It's called follicular stimulating hormone, starts to really ramp up because the ovaries are stopped. They're not working as well, right? They're not pumping out like they should be. So then the brain gets that signal back that nothing's happening downstairs. So it goes, hey, the knocking gets louder. It sends a louder signal. So this starts to increase. So we get above 20. We're like, ooh, you're starting to get there. Above 25, you get a couple of these readings back to back. While this is not necessarily diagnostic, unless we don't have a uterus and we can't tell if you're, it's harder to tell what's going on. And then we rely on this a little bit more, as well as, is she having symptoms of menopause? Are we having vasomotor symptoms? Are we having GSM symptoms, genitourinary symptoms? Then we can say, okay, we're probably in that range. But we'll have an increase of the FSH as it's trying to tell the ovaries to kick back in, and the ovaries are like, I don't think so. We're pretty much done here. Thanks. And then we hit the menopause transition, which is at 0. That's 12 months without a cycle. Okay. Like I said, usually around the age 50 to 52, might be a little bit later for some women. And some women, if they're in their 40s, we call that early menopause, which has its own health implications. Okay. All right. Myth number 2, perimenopause and menopause are the same thing. They're not. So as you can see here, the menopause transition, perimenopause, also known as premenopause, can start as early as age 35, typically thought of as the 40s, the age, your 40s. In your 40s, you're considered to be perimenopause. More common to see symptoms in your 40s than it is in your 30s, but it is happening earlier and earlier. And they're usually more subtle, so it's harder to pick up. And then we transition when you've had 12 months without any cycle at all. We'll have a different episode where we talk about post-menopause bleeding, because that's also something I'm concerned that we need to be aware of. But after that, then we're considered to be in post-menopause. So those are two distinct, it's on a spectrum, but they're also distinct events. Okay. Myth number 3, hot flashes and mood swings are the only symptoms. So we used to only treat for hot flashes. Like that was the indication to get on treatment for menopause, was only for like hot flashes, and then also for genitourinary syndrome, where we're having like vaginal dryness and irritation and pain and frequent UTIs and things like that. But now that we know more, this is only a list of the common signs and symptoms. There's just about almost 100 that we can say. More and more as we're looking into this, we're finding there's more and more symptoms that are linked to menopause and perimenopause. So we have changes in the menstrual cycle, like we talked about early. We have a 7-day difference, which is subtle. If you're not tracking, you may not really even notice that, and then we can get a lot less subtle with more than 60 days. And then we can have the night sweats and the hot flashes. Somewhere between 50 to 80% of women will experience this. It's pretty significant. And it's also on a spectrum. Some have, it's kind of annoying. Some have, it's debilitating and I can't sleep and my life is miserable. And obviously they are the ones we're going to talk to about getting on some estrogen. Vaginal changes, like I talked about. So the dryness, the irritation, the pain, which also links to low libido, though it's not always one and the same. Libido is complex. There is the mental aspects, there's the physical aspects of it. If you want to know more, the book Come As You Are, I can't remember the name of the author, but she is freaking fantastic. She's a PhD and she teaches all about libido and talks about the brakes and the accelerators, and super fascinating book. And any woman who comes to me with complaints of low libido and issues in that realm, I treat them, but I also send them to that book. So I was like, you got to read this. This is amazing. And it's going to help you with all the other aspects of sexuality in your sex life and everything, which is important. It's an important part of your health. Low energy is another one. And that also is related to your cortisol levels are changing. And then we've got changes in mood, increase in belly fat, decrease in muscle mass, increase in headaches and migraines is really common. I see that too. We have other weird symptoms too, like itchy ears, because there's estrogen receptors in your ears. Why not? And dizziness is another common one. So we want to rule out there's any cardiac issues going on there, but just drops in estrogen can also contribute to that. All right, myth number 4. Are we already on myth number 4? That was fast. Hormone therapy is the only solution. No, that's not true. Hormone therapy can be very beneficial to many, many women. Some women don't qualify. Some women prefer not to, which is totally fine. I am here to educate and help you make an informed decision. That's my job. So if you don't prefer to do one treatment or another, that's your right. So long as you are cognitively aware, you don't have dementia or anything, and you can make your own decisions, right? So it's called patient autonomy. It's a thing. Anyways, so other approaches that we can use, especially if we're coming in kind of towards this earlier time period, I love to use herbals. So if the progesterone is low and they've got symptoms, I typically will use Vitex. I really love Thorne's Metabalance. That one's fantastic. And now I'm telling you what I use, but I'm saying that I use this after I, as a provider, have a relationship with a patient. We've done labs. I've done their intake. I've taken their history. I know what their medications they're on, what supplements they're on, what their history is. And then we make a decision. So I'm not advocating that anyone just go out and start taking supplements. Okay. You need to be aware that not everything out there is benign. Even herbal supplements can be very potent. They can interact with other drugs. They can interact with other supplements. They can interact with food. So we need to be very aware of that and not just willy-nilly be throwing stuff around. So I like to use Vitex if the progesterone is low, which is a common, that's like the first thing that drops. DIM is great if the estrogen is getting too high. And by the way, it will. So you think it's just like, oh, estrogen, and then steady decline. Absolutely not. No, why would it do that? No, it's going to like go crazy on us for a little bit. So we can literally be high on estrogen in addition to the progesterone being low. So then we feel even higher, we'll have more estrogen dominance. And when we talk about estrogen dominance, that's what we're talking about. We're talking about in relation to progesterone. And then in and of itself as well, there can be an upper limit. There is an upper limit for estrogen. We can have that dominance situation. We're going to have symptoms of high estrogen. Things like really painful periods, really heavy periods, lots of clots. And then we can even get into things like, endometriosis and things like that can be contributed to alterations in the hormone levels and inflammation in the body in general. So something that can definitely be treated, not always requiring surgery and removal. So, and then what else do I like to use? I love DHEA. DHEA comes from the adrenal glands. It is a precursor hormone. And what that does is it is then turned into testosterone and estrogen. So DHEA. And I need like the full chart. I will do that later. So DHEA can be turned into our other sex hormones such as estrogen, testosterone, progesterone even. So, but it really loves getting turned into testosterone in women that I've noticed. So especially if the testosterone is running a little bit low, I love that one. If you have chronic adrenal fatigue situation going on where your cortisol levels are actually really low because they've been high for so long and ramped up for so long that now the body's adapted and it's down regulated that system. It's another good one to use again after proper intake. And we've talked about it. We don't just willy-nilly throw people on things without knowing all of the details about what's going on and having a diagnosis. Okay. All right, myth number 5, final one. There's nothing you can do to control weight gain. This kind of goes along with it's inevitable to get old, which it is, but do we have to resign ourselves to so much of these things? No. Like our muscle mass, does it decrease over time? Yeah, but also are people lifting weights and as active as they used to be? Not really. So we need to give the body the stimulus it needs to continue to utilize these things to like build muscle. Estrogen is an anabolic hormone, which means it builds. And it builds things like muscle. So it's building our muscles. And as we're losing that, we need to give the body a different signal to continue to build. It also builds bones. So as we're losing that signal, we got to give the body a different signal so it continues to preserve bone mass and even build bone mass. And yes, we can build bone mass even into menopause, let alone, of course, in perimenopause, we absolutely can. But even into menopause, we can build bone mass, we can build muscle, and we can improve body composition. But it's with proper diet, exercise, and maybe some supplements to help support the body in doing that. So it's a holistic thing that we can do. Giving you one thing is not going to fix it. I can't just give you estrogen and you like, boom, all your problems go away. I wish. That would be awesome. That's not how this works. So, all right. So those are the myths. These is the whole process over here. So those were the 5 myths that we discussed. I hope that this was helpful and that you got something out of it. We do have our brand new 21-day perimenopause boot camp, which is a really fun program that I put together for you guys. You can run through it in like an hour. Like, it doesn't even take that much time, but it gives you a meal plan that you can work with, and it's adaptable, a fitness routine that we can modify to any level. You got modules in there to learn more about what's going on and how you can be your own advocate and take charge of your health. And we're also going to do live Zoom calls, kind of like open office hours, where I will get on with you guys and you can ask me questions and we just like talk like normal people. So there's a lot of support within this program that you're not going to find anywhere else. Like, I probably put way too much in it and probably I'm not charging enough, but whatever. I really want to help people. And this is just one way that I can do that, where you can get to know what my style is and hopefully get some really good benefits out of it. And I know you will. If you do what is recommended, what's prescribed in there, you are going to feel better. You're going to have some changes in your body that are going to be beneficial to you. You're going to love it. So Black Friday special is going on until the end of November. It's a BOGO, so buy one, get one. And also you get a free brief initial consult with me. So definitely take advantage of that offer, as this program will be run again in January, but without all that fun stuff added to it. So this is our maiden voyage, if you will. So we're going to run it through the end of November, and then doors are going to close, and that'll be it until January, when the price is going to be adjusted and it will be kind of a different offering there. So, all right, thank you so much for joining me. And if you are interested in that boot camp, you can check, I'll put the link below, and also you can just DM me and say boot camp, or if you just want to talk about your hormones, if you're struggling and you're finding it really hard to get the help that you need, DM me hormone help, and that'll start the conversation. We can get you the help that you need. All right. Hope you guys have a great rest of your day. Take care.